So I am Natia Ingram. Welcome to the Measuring the Impact session. I'm the original data analyst from the Office of Marijuana Policy team here in Denver. I have with me here today a number of experts in various facets of marijuana legalization impact analysis. Covering the public health perspective is Caitlin Hall, a statistical analyst from the Colorado Department of Public Health and Education. Want to raise your hand? That one. Julia Dilley, an epidemiologist from the Oregon Health Authority. Catherine DeYoung, another epidemiologist, but from Denver Health. And then Jack Reed, who will be covering crime. He's with the Department of Public Safety for the state of Colorado. So we're going to start today's session with a brief overview of the national landscape of marijuana policy as it stands today. Then Caitlin's going to kick off a little discussion of data limitations so that we can tell you why all the data we're about to present may not be accurate. We'll talk about what you could expect based on history of illicit substances that have been legalized. And then we're really going to do a pretty deep dive into a comparison of public health data so far from Colorado, Oregon, Washington, and Alaska. Jack will do a pretty robust session on public safety data impacts. And then I'll wrap up with a brief overview of some environmental, economic, and operational impacts that we've seen here in Denver and in the state of Colorado. So, as most of you know, as of right now, 8 states in the District of Columbia have moved forward to legalize fully recreational marijuana. 32 states and the District of Columbia have some form of medical marijuana program. 18 states have expressly allowed for the use of CBD oils. And 13 states, including Nebraska, have decriminalized the drug, which leaves only 3 states with no form of legalization or decriminalization law in the books, those being Idaho, South Dakota, and Kansas. So we are much further down the path of legalization than I think a lot of people realize. Now, this rapid expansion of legalization across the country is a direct result of shifting public opinion. Legalization supporters have been gaining in the polls for almost 2 decades, and in the last 5 years, they've taken the majority. And that shift is being catapulted by that millennial generation, the blue line represented in the graph to the right, although the trend is also prevalent in the baby boomers in Generation X. And so what this means is that legalization questions are coming to your ballots, and it is important that we have the data and the ability to inform lawmakers and citizens as not only to how they want to vote on whether or not to legalize, but how they actually want to implement their systems if they do move in the direction of legalization. So with that foundation laid, I'm going to hand it over to Caitlin, who's going to talk about data limitations.
All right. Before we talk about limitations, I just want to briefly go over the different categories of data that we use to measure the impacts of marijuana legalization. So there's 3 main categories of data sources that we use. The first being survey data. The second I've labeled public health data, but I think I'm going to rename this to just health outcomes data. And then the third is public safety data. So in survey data, we can look at youth marijuana use trends and adult marijuana use trends. And this depends on the survey that you look at because they are asked of different ages. So for youth marijuana use, we tend to look at Healthy Kids Colorado here in the state of Colorado, which is the same survey as the Youth Risk Behavioral Surveillance System, which is a national CDC survey. And there's also Monitoring the Future and the National Survey on Drug Use and Health that track youth use. And for adult marijuana use, we use the Behavioral Risk Factor Surveillance System and the National Survey on Drug Use and Health. For health outcomes data, we have 3 main systems that we use, the first being syndromic surveillance systems, which capture almost in real time emergency room discharges. We also use hospital and emergency department discharges and poison center data to measure marijuana health outcomes. And among public safety data, we look at marijuana arrests and offenses, driving under the influence of drugs, and DUID treatment admissions, toxicology reports. We also look at traffic accidents related to marijuana using the fatality analysis reporting system. And we can also look at adult probation or drug test results. So for each of these data categories, there are some very distinct limitations that should be kept in mind when you're looking at these in your state. Among survey data, we have some limitations in just self-reporting substance use in general. People are less likely to self-report their substance use, especially if they're talking to someone that may be intimidating, such as the government or public health. Also, with youth surveys, youth may be given a survey in a setting where they're not comfortable to freely talk about their substance use, which can then affect your outcomes or measuring the use. Also, youth that use marijuana may not be attending schools, so any school-based survey may be not capturing this population. And for adult use surveys, again, we have this self-report substance use limitation, but also populations that use marijuana may be less likely to answer a survey, so they could be missed. And often with all of our survey data regarding substance use, we have the issue of small sample sizes, so it's very hard to narrow down your population by demographics and still get reliable estimates. So it's also a good idea just to make sure that you have measures of variance or confidence intervals when you're looking at your data. For health outcomes data, most of marijuana exposures are captured in some sort of standardized coding system. For discharge data, that could be the International Classification of Disease Coding System, or ICD codes. I'll just call them discharge codes. And these are intended for billing purposes and not for capturing exposures. And so there are some limitations around that. Also with health outcomes data, healthcare providers that are in an environment where they're more aware about marijuana legalization may be more apt to ask their patients, did you use marijuana, or did you use any substance for that matter? And so that can also influence what your data looks like when you're trying to capture discharges involving marijuana exposures. Also, this discharge coding system, it does not necessarily mean that marijuana was the cause of the healthcare encounter. It could just be that we're capturing marijuana use, much like you capture tobacco and alcohol use. When you visit the emergency room, the nurses always ask you, did you use tobacco? Do you use alcohol? We could be capturing marijuana use in these data systems. And my final limitation for health outcomes data is that most of these systems are counting healthcare encounters as an event. They're not counting individuals. So you could have repeat offenders that may inflate your numbers slightly. Among public safety data, we have some limitations that are reflected by policy and resource allocation. So an example of a policy limitation in Denver is that if a person is intoxicated with alcohol and they're pulled over, they would receive a DUI regardless if they were impaired with alcohol or not, based on the policy. So in your data, that may come through as a DUI, and then it would never be counted as a DUID. And then a limitation for resource allocation in Denver, an example is Denver has the drug recognition expert force that gives DUIDs, and this force was doubled recently, and when we doubled this force in Denver, we also saw a doubling in DUIDs in our data. So now that I've kind of briefly described the limitations, I wanted to give historical examples of what happens when you have a prohibition and that prohibition is lifted. And then another example I wanted to give is what happens when you have a new product hit the market and how both of these things may impact public health data. So my first example is the prohibition of alcohol in the early 1900s. So prohibition started around 1920, and this graph is showing the top solid line is cirrhosis, death due to cirrhosis of the liver. And then the bottom dashed line is the consumption of absolute alcohol from spirits and wine. And as you can see, when prohibition started around late 19-teens, early 1920s, there was a drop-off in both of these conditions, the use and death due to cirrhosis of the liver. But then when prohibition was lifted around 1930, there was an increase in both cirrhosis, death due to cirrhosis of the liver and alcohol consumption. Unfortunately, they didn't track alcohol consumption during Prohibition. I'm not sure why. But the moral of the story is if you have an effective prohibition, when that prohibition is lifted, you could see trends like this in your data due to the lifting of the prohibition. My second example is highlighting what happens to health outcomes data when a new substance hits the market. And this kind of parallels with marijuana, because when marijuana hit the market, it was not the same marijuana from 1970. It hit the market and diversified into 1,000 products. We now have edible products, marijuana lasagna, marijuana peanut butter. So there's lots of new ways to consume marijuana. But around 2010, e-cigarettes and liquid nicotine became widely available in the United States. And what this figure is showing is calls to the Poison Center with e-cigarette and liquid nicotine exposures. And as you can see, 1 year later, we start to pick up calls to the Poison Center, and this increases and peaks in 2014 with around 4,000 calls nationally related to e-cigarettes and liquid nicotine. But then you also see a decrease after 2014, which could imply that there's a learning curve to a new product hitting the market. So also this should be kept in mind when you're looking at any health outcomes data related to marijuana, as when marijuana hits a market, it will diversify into many new products. And now I'm going to turn it over to Julia to talk about some use data.
Thank you. So I'm going to talk a little bit about the first type of data that Caitlin outlined, of the 3 types of data that we look at to try and decide what's happening because of legalization, and that's survey data. So, of course, one of the very first things people ask the legalized states when we talk about legalization is, so what's happening? What are people doing that's different? And so I just share this picture of a billboard from outside of the Portland area from a couple months ago, and I will just say to you that we are seeing some very interesting things that we have not seen before. So first, let's talk about youth. Of course, one of the very great concerns about legalization is potential impact on young people. Of the 4 early legalized states, we've aggregated here the school-based survey data from each state, and I'm going to show you some data looking at the pre-market period, so before marijuana retailers opened in the state, and then after. For the state of Alaska, we don't have post data or after retail market opening data yet, but I'm including their pre-data for you. In Washington state, the market actually opened in 2014, but it opened rather slowly. There were some challenges with just building the new system. So here I've classified 2014 as pre-market, but we sometimes call it post-market depending on what we're looking at. All of these surveys are state-sponsored, school-based surveys of high school-aged young people. They use paper forms, and kids fill in bubbles to tell us about the kinds of things we're doing. We classify current marijuana use among youth as any use in the past 30 days, and that's a nationally standardized definition. So this is a rather busy graph showing you the 4 states' data for any current marijuana use or any use in the past 30 days among young people. The navy and dotted lines are national comparison data. The upper one is Monitoring the Future 12th grade, and the lower one is Monitoring the Future 10th grade. So one thing you'll notice immediately is that older kids are more likely to use marijuana than younger kids. You can see that in the national data here. And then with the 4 states, their data pretty much fall in between because they're using, or they include information from young people who are sort of between those 2 age groups. For Oregon, we have 11th graders. Colorado is 9th to 12th combined. Alaska's YRBS has 9th to 12th combined also, and Washington is 10th grade. So it's a little difficult to see what's going on here, so I'm going to isolate to just the 3 states that have pre and post market data for young people, and I'm keeping the national trend line in there so you can see that for comparison. So one thing that from a public health perspective, I've been very grateful to be observing is that so far in the legalized states, among young people overall, the trends look a lot like the national trends. So for example, in Washington State, the rate of marijuana use among young people is a little higher than the nation, but the trend is going down, and it looks a lot like the national trend for 10th graders. Same thing with Oregon and Colorado for slightly older young people. They look a lot like the national trend for the 12th graders. So in addition to use, let's look at some prevention indicators among young people. So one of the important indicators that we want to watch is how easy do young people think it is to get marijuana if they want to get some. So here for three of the states where we have pre and post data, this is the percentage of young people who say it's easy, either very easy or somewhat easy, to get marijuana if they want to get some. And the orange arrow is pointing up because from a prevention perspective, we would like to see that go higher. So for the state of Colorado, it looks like it's trending up a little bit, but that difference is non-significant. For the state of Washington, again, 2014 is kind of a weird year because the market had been opening slowly, but in 2016 we actually saw a statistically significant decline in the percentage of young people who said it was easy to get marijuana if they wanted some. That's weird, right? Like not at all what you'd expect after retailers opened. But one thing that happened in Washington State, which was a very good thing, was that in the process of regulating the retail recreational market, Washington State also finally started to regulate the previously unsupervised medical market. So there were a lot of medical dispensaries operating in Washington during 2012 and then through 2014 without any sort of oversight or supervision. So as the retail market was coming under regulation, that medical market also got collapsed into the retail market. And so it was no longer the case that we had these dispensaries unlicensed, unchecked, operating. And so maybe that's what we're seeing here in terms of in Washington State, young people saying it's not as easy to get marijuana after legalization. In Oregon, different story. We saw a statistically significant, although not large, increase in the percentage of kids who said it was easy to get marijuana if they wanted some. So parents really do make a difference in the choices of young people. This is a graph of the percentage of kids who said their parents would disapprove of them using marijuana. And here, the orange arrow points down because parent attitudes disapprove. Oh, risk increase, sorry. The risk, we would not like to see that go down. We would like to see it go up. I may have said that the opposite way in the previous slide. You all probably figured that out. So in Colorado, we saw declines in the percentage of parents who disapproved of using marijuana, a non-significant decline. In Washington, it sort of stayed about the same. And in Oregon, however, we did see a decline in the percentage of parents who said they disapproved of, or who the youth thought would disapprove of their using marijuana. So that is a troubling trend. In Alaska, we don't have post-market data yet, but their measure does appear to be lower than the other states, so we'll certainly want to keep an eye on that. And then last, perceived harm from regular, defined as weekly use of marijuana among young people. Here, we're worried if it goes down, and we did see it go down significantly in Colorado and Oregon. In this case, Alaska seems a little bit more on par with Oregon, at least. And in Washington State, we did see it go down, but not significantly, and certainly not significantly more after the retail market opening. So a similar measure to the one you just saw that was collected in state-specific data sets is collected on the National Survey on Drug Use and Health, which is the national standard way of measuring substance abuse and related factors among young people and adults. And so here what I've got is the national trend in young people who say it's harmful to use marijuana once or twice a week. And these are kids aged 12 to 17 combined, so it's a pretty wide age range combined. What you can see is nationally, I'm sure this is not news to you folks, the percentage of kids who think weekly marijuana use is harmful has been declining over time. And then here I've got also charted the individual states' results, and what you can see there is that these states are trending downward and have been lower than the nation for quite some time, and they seem to be trending downward similar to the nation. So now let's turn to adults. First, I'm going to show you that same measure I just showed you for young people. Here's the same thing for adults ages 26 and above. Here again, we see that the states are all, first thing is adults are also becoming less and less likely to say that marijuana use is harmful if you use it once or twice a week. All the legalized states are tracking similarly declining trends and have been tracking lower than the nation over time. Here, I've put a little blue diamond on there to show the youth rate for the nation, and what this means is that adults are a little more likely to say marijuana use is harmful on a weekly basis in comparison to youth. So the last thing I'll share is current marijuana use among adults, again using the same nationally established definition of any use in the past 30 days. Here again, the national trend is going up slightly over time, and here are the 4 legalized states, which for recent years are all tracking higher than the nation. Washington has the longest history of measuring this in their adult surveillance system. It's been going up over time, particularly since around 2013. For Colorado and Alaska, at least so far, those are statistically not changing trends in recent years. And for the state of Oregon, we also, this 2016 data point is brand new from about a week ago, and we were very surprised to see how much it had increased in the past year. And that's probably reflective of the full retail market opening in the state of Oregon in 2016. So now I'm going to turn it over to Catherine to talk about the next type of data, which is health outcomes.
Thank you. So I'll be talking about health outcomes, and one of the important things to keep in mind with this data is we're really looking at acute health outcomes, outcomes that might be expected to emerge shortly after a person uses. Long-term health outcomes are a lot harder to study. Obviously, they take longer time to emerge. So things like, does smoking marijuana twice a week give you cancer? Those types of things will take a lot longer time for us to find out and will be harder to pin down. So we're just looking at immediate trends. So the first data source I'll be talking about is called syndromic surveillance. This is a timely measure of what's happening at emergency departments across the country. The system is called Essence, and no, I don't remember what it stands for. So the cool thing is that we have Essence in a few counties in Colorado as well as in Oregon. So I'm actually going to start with Oregon first. Interesting thing with Oregon and Colorado, we have our trends are from the same time period, but you might look at them as a continuation, a spreading out of a trend. So what I mean is Oregon, early retail sales begin in October 2015, and whereas in Colorado, we've had retail marijuana since 2014. So I'm showing the Oregon slides first as kind of a potentially an answer to the question of do the acute health effects of marijuana, as at least shown by this way of measuring it, level out over time like you saw with e-cigs. So here we see, this increasing trend from October 2015 to June 2017, and it increases somewhat. Now, I should say these rates are per 1,000 emergency department visits. So it's the number of potentially marijuana-related ED visits divided by the total number of ED visits at that time. So that's kind of what that looks like. So here you see an increase from, say, a rate of 3.4 to a rate of 6.0. And again, these are really, these should be looked at as an indicator, not as an absolute definition of how many people are going to the emergency department because they had too much marijuana. So here we are. This is, the sort of immediately post-legalization trend. And then looking at Colorado, which, as I said, legalized in 2014, you see, so we actually started, October 2015, we were at about a rate of 6.1 per thousand, and that seems to be leveling off down to a rate of 3.8 most recently. So again, it's only an indicator. It doesn't tell us anything more than it tells us, but it's an indicator. So if you're curious about, sort of what's underneath the hood with this data, in Oregon, this data source represents 60 out of 60 emergency department receiving hospitals in all counties of Oregon. And in Colorado, we have 6 Front Range counties participating in this, and we have 25 out of the 27 emergency department receiving hospitals. And another caveat, a giant caveat with this data source is that data quality is incredibly variable. So this is something that hospitals do because they get some money from the federal government for reporting this kind of data to local health departments, but participation may vary. If you're even more curious, this is the query that we ran. If you have Essence at your local county or state, take a picture of this. Give us a contact if you are curious, but if not, I'll move on. Poison center data is another acute, quick measure, fairly timely, of what's going on. So some caveats with that. Poison center. So who calls the poison center? Parents. Parents whose kid did something inexplicable, such as eating an edible or eating, they just do this. So keep that in mind. Again, as we said, every indicator will have its own flaws. And so part of the challenge is saying, okay, we'll do how many of the indicators tell us about the same thing. So I think as you're thinking about marijuana epidemiology and most epidemiology, the question is not what exactly, you're never going to be able to answer exactly the question, how many people are getting into trouble with marijuana and how bad is it, and are our interventions working? You're not ever going to be able to answer that exactly. But you are going to be able to say, okay, we can look at as many different metrics as possible over time and see, do they agree? Why might they disagree? That's where you start. So I'll be showing you a couple of slides from screenshots of a dashboard that I've been working at Denver Public Health. Rocky Mountain Poison Center is the poison center for a number of states, including Colorado and actually Hawaii. And we've been producing a dashboard, an interactive dashboard that will go on our website at some point this year, that people can use to find out the answer to their questions about what's happening. So first, one of the things that we are very interested in is understanding marijuana in the context of other substances and drugs of concern. So here you can see we've got the number of calls and the rate of calls for marijuana, alcohol, and opioids. So these are what the definition of this is. If a person called the poison center and they were concerned about a substance they'd consumed, if they consumed marijuana, that's a marijuana call. A person might consume more than just marijuana, and they're rolled in together with this. So the number of marijuana calls, and this is in Denver from 2001 to 2016, was 303. That's a rate of 370 per 100,000 calls. And that's, you can see how that stacks up against alcohol and opioids. So I think the other thing to know about marijuana epidemiology is what you're looking at is a symptom, maybe a symptom of people whose lives are not going well, people who are not handling their circumstances well. It's a symptom of mental health. And so, we can look at marijuana in a lot of different ways, and one of those ways kind of ties to people who are using and getting into trouble with other drugs as well. So looking at that over time, here we're looking at the count of calls. So down here in orange or yellow is the number of marijuana calls. We've got anywhere between 15 to about 40 per year in Denver. Now this is just Denver. And then here's the alcohol and opioids. Of note, the Prescription Drug Monitoring Program changed its laws in 2014. So it's an interesting trend. I think it would be interesting also if we split out, this is prescription opioids as well as heroin. So it might be interesting to see if those two trends are tracking similarly or if they're different. So the problem with calls, the number of calls is, what's happened in Denver since 2001? Well, a lot of things have happened, including big population change. So if you saw just an increase in the number of calls, that might tell you, well, more people have moved here. Also, awareness of the poison center changes over time. So the important thing that we do is we look at both counts and rates. Rates tell us, okay, again, what's the number divided by the total number for that population? So you see a similar trend. And, with a couple of bumps when in 2010, medical marijuana was commercialized. And then 2014, big bump here when retail stores opened. The other important question, obviously, is what's going on with kids. So and again here, an important thing to know is there's a difference between an individual's experience and what's happening at the population level. At the population level, this is really small. A total of 41 0 to 5-year-olds between 2001 and 2016 in Denver. But that was a significant event for those 41 kids and their parents. And, so there's kind of this balance between what's going on with the individual and what's going on at the population level. All right, now on to Caitlin for CHA data.
I'm back. And now I wanted to share with you guys one of my favorite data sets, which is the Colorado Hospital Association data. I think it's my favorite because it's so challenging and complex. But just to give you a little perspective on this data source, it represents approximately 100 hospitals in Colorado, which we think represents the state of acute care hospitals. So it doesn't include military hospitals or any kind of long-term care. Also, we have data for hospital discharges going back to year 2000, but for emergency department discharges, we only have data going back to year 2011. And the way we use this data, I alluded to earlier, we use a standardized coding system that's used across the country with all discharge data to count marijuana exposures. So there are 4 marijuana codes that we're counting in this analysis that would indicate marijuana was involved. And I'm just going to highlight again that could be marijuana use, it could be a poisoning, it could be abuse, it could be intoxication. It's not clear. We just know marijuana was involved in the visit. So we look at this data over time, as far back as we can. Like I said, 2000 is as far as we can go. And this figure is showing the rates of hospitalizations in the dotted lines and the rates of emergency department visits in the solid line involving marijuana over time. And this is per 100,000 visits, not individuals. And each vertical line here is representing a different time point in Colorado's marijuana legalization history. The first time point in 2001, medical marijuana became legalized. We saw a slight increase in the rates of hospitalization discharges involving marijuana or indicating marijuana. And then the second time point, when medical marijuana became commercialized, this is where we started seeing medical marijuana dispensaries in Colorado. We saw another increase in our hospitalization discharges indicating marijuana use. And then with legalization in 2014, we saw an increase in both hospitalizations and emergency department visits that involved marijuana. However, with emergency department visits, we have seen a decrease in 2015 with ED visits involving marijuana, and this could be something like what I alluded to earlier with the e-cigarettes and nicotine, liquid nicotine, where we are now seeing our population learning how to use the products. But we're still not sold on that reason, so we're going to continue to track this forward in time. And the hospitalization rate has continued to increase into 2015, 2 years after legalization. So we wanted to put this in context of other drugs, because when you look at it just alone, it's not really clear, well, how does this compare to alcohol? So we ran the exact same analysis where we looked at each emergency department and hospitalization visit, and we looked for any mention of a marijuana code or any mention of an alcohol, opioid, or stimulants codes. These are not mutually exclusive. People can be in multiple lines here. But what we see is that the rate of alcohol hospitalizations is a lot higher than marijuana still, though marijuana has been increasing. But the rate of marijuana hospitalizations is still higher than opioids and stimulants, and this has been true since about 2012. We also looked at this in emergency department visits, and we saw a similar trend where the rates of ED visits involving alcohol is much higher than marijuana. That's the top blue line. Marijuana is the green line. We see the trend with it decreasing, but it's still higher than stimulants and opioid-related ED visits. So then we wanted to look at hospitalizations and ED visits by age categories to get an idea of who is coming into the hospital in the emergency department. So this graph is breaking down our time periods on the left-hand side for prior to legalization, which would just be year 2000, and medical marijuana legalization from 2001 to 2009. Then we have medical marijuana commercialization from 2010 to 13, and then recreational legalization starting in 2014. And it's hard to make out the colors probably for you guys, but the highest bars here are young adults and adolescents. That's ages 9 to 25 years of age. And as we go through time, their rates are significantly increasing for hospitalizations involving marijuana. When we look at emergency department visits involving marijuana, we see the same trend where the highest rates are among young adults and adolescents. And this is also statistically increasing across legalization time periods. So what is the reasons, what is causing this? What could be driving these increases? Well, one thing, it could be real, but based on all the limitations that I've already shared with you, it's most likely partially real, but then partially due to some other factors. These factors may include that marijuana users that maybe were on the gray market before legalization are now going to the hospital or emergency department visits. They feel more comfortable admitting that they had an adverse health effect and then admitting to their provider that they were using marijuana when they had an adverse health effect. Also, providers may be more aware of marijuana. They may drive to their hospital and pass 3 dispensaries on the way, and they come in and the marijuana is on the brain, so they're asking their patients, did you use marijuana, when they come in with related symptoms. It could be real in that higher potency products could be driving more healthcare encounters, and it could be real in that naive marijuana users do not know how to use these high potency products and are experiencing overdosing that lead to adverse health effects. And then we could just be capturing marijuana use because you have to also consider this data is not just residents, we also have tourists in this data, so we could be capturing people coming to Colorado, using marijuana, going to the emergency department because they have flu, and then the healthcare provider asks them, did you use marijuana while you're here? And so that could be picked up in the trends. One other indicator we look at when we look at this data are the primary diagnosis, the reason we believe why the patient may have gone to the hospital or the emergency department. And here is a graph showing the primary diagnosis on the left. These are just standardized categories within the coding system. And we're showing the prevalence ratios of the prevalence of that primary diagnosis among ED visits involving marijuana compared to ED visits not involving marijuana. And what we found was among emergency department visits, there was a 5-fold higher prevalence of mental illness in those involving marijuana compared to those not involving marijuana. And we also found a 2-fold higher prevalence of unclassified codes and E-codes. And this category is popping up because it includes the code for altered mental status. And when we looked at the same indicator in hospitalizations, we again saw an increase in mental illness with a 9-fold higher prevalence of mental illness among hospitalizations involving marijuana compared to those not involving marijuana. So there are a couple of reasons for why this is happening. Substance use historically is just related to mental health illness, and we could just be capturing that relationship in this data. Also, we're capturing chronic and acute mental illness here, so people could be using marijuana to treat chronic mental health conditions. And we could be also capturing acute mental health conditions that are coming in, like anxiety or psychosis, which have been related with marijuana use in the literature. We are transitioning into a new coding system. You may know of it, maybe not. It's called ICD-10-CM. In this coding system, we went from 4 marijuana codes to about 40. So we should be able to clarify why people are coming in with marijuana codes and break that out into different categories of marijuana use for use, poisonings, and abuse. And with that, I'm going to turn it over to Jack. He's going to talk about our public safety data.
That would be funny if I fell off the back of the stage. For somebody, anyway. Sorry. Okay. So actually, first, I'm going to talk about some treatment admission data. One thing I would like to thank the conference organizers for doing is putting us at this time in the morning where you've all had your coffee, you're awake. Normally, when you put a data presentation like right after lunch or at the end of the day, people are either leaving or they're falling asleep. So thank you very much to the organizers. So I'm actually first going to talk about some treatment admission data. This is because we don't have any people from behavioral health here, and they're really, really good to me and actually give me all of their treatment data, which is great. So these are 3 lines that look at the rate of treatment admissions where marijuana is indicated as the person's primary drug of abuse. And what we see here, and this is interesting, and the people of behavioral health are still a little confused by this, is we have seen decreases in our treatment admission rates where marijuana is indicated as the primary drug. Especially for those 18 to 20-year-olds whose rate of use is much higher, that has gone down, and realistically in the juvenile, so 17 and under, as well as the 21 and older range, it's effectively been flat. So we haven't really seen any major changes in the number of people that are showing up for treatment. One thing though is there's about a 10-year gap between first use and first treatment. And so as we move forward, especially over the next probably 7 to 8 years, it'll be interesting to see what starts happening with this trend. One question we often get is, you can get referred to treatment by the criminal justice system. If you're you could get referred for, if you need to get your license back after DUI, you can get referred because you're in drug court, you can get referred because you're on probation. So what this shows is the percentage of people who are referred for treatment where marijuana is their primary drug by the justice system. And so again, this is an interesting graph. We see a major increase in youth being referred for treatment, but we really don't see any major changes for those 18 and over who are involved in the justice system. And that's where the referrals are coming from. So, when you think about the previous slide, you note the number of people that are coming into treatment as youth. More of them now are definitely coming in due to interaction with the criminal justice system because it is still illegal for them to use and to possess marijuana. This is, again, I love us because we give you the easiest slides in the world to parse. This is actually a slide on the frequency of use in the 30 days prior to coming into treatment. So these are people that, they have issues with the drug, which is why they're in treatment. What we see here, that first chunk, are the people who have reported no use in the month prior to treatment. So a little over half of people reported no use if we go back to 2008. And that goes down to about 40%. If you look at that far one, those are people who are saying, I'm using daily or near daily. And that has over doubled in this period between 2008 and 2016. And so now about a quarter of the people that are coming into treatment are saying, I'm using daily or near daily in that month prior to coming into treatment. And so, it goes from 1 in 10 to 1 in 4 who are saying, and so even though we see that rate of people going into treatment going down, right, the severity of their use prior to coming into treatment is increasing. Okay, now onto the stuff I'm actually qualified to talk about, public safety data. The one question that I get is, well, we're on the road to legalizing, or we've legalized, what do we need to do with our data? And my suggestion is always start now. Actually, start 3 years ago. Because I didn't get this job until we were already basically a year into legalization. And so as a state, we have been playing catch up. And making sure that you actually have the information so that when people come and ask you questions, you can answer them is extremely important. Okay, so let's just start with marijuana arrest rates. So these are arrests for marijuana as one of the reasons for the arrest. It could be possession, it could be distribution, it could be manufacture, right? We only have data going back to 2012 because in 2012 we became an incident-based reporting state at 100%, which is fantastic. We get awesome data about every single offense in an arrest. But it also means that the data prior to 2012 is completely non-comparable. So what we've seen is, as you would expect, the arrest rate completely drops out when you get to when it's legalized. So in 2013, it's legalized. We see, basically the arrest rates drop in half. 80% of marijuana arrests are for possession, and so this absolutely makes sense. When you're an adult, possession is now legal. They were the vast majority of arrests before. And so we see this rate completely wash out, which frankly was the point. So there's different ways to cut this up, right? We've been talking about equity throughout the conference. And so when you look at the rate of marijuana arrests by race, what we see in Colorado is that the white and Hispanic rates for marijuana arrests are effectively the same. But the arrest rate for African Americans, where it's a marijuana offense, is double. It was double before legalization, and while it's gone down for all racial categories, it's still double. And at this point, the rate for African American arrests now is about what it was for whites prior to legalization. This is it broken down by age category. Again, youth 10 to 17, we haven't seen that big a drop in their arrest rates pre to post legalization. Definitely saw a bigger drop in the 18 to 20 group, but it's kind of flatlined now. And again, in that 21 and older group, we've seen the rates completely drop out, and I don't think that there's going to be any change in that necessarily, just because, as we'll see later, the arrests that are happening more prevalently now are higher level ones. And then when we look at it by gender, women are arrested at about 1/4 the rate of men. When you look at the usage data don't show that big a disparity, but women are better at using and not getting arrested. Because women are smarter than men. Okay, so the one thing that, if you go to the law enforcement panels, you will definitely hear is that, okay, yes, we took away possession, right? Possession tickets are a 5-minute ticket. In many places, it was, effectively just a fine. But what is happening for those higher level marijuana infractions, right? So these are actually court filings. I get some better data on the actual level of the offense when I have court filings rather than arrests, so that's why I've kind of switched to that now. So what we see here, these are arrests for, or filings for possession with intent, manufacture, distribution, and conspiracy. And so we see it, it's effectively flat from 08 to about 12. It drops, as soon as we hit legalization, the filings really drop out. And there's a number of reasons for this. One being that much of this was made legal. The other being that there were very few bright lines for law enforcement when it came to marijuana. Prior to legalization, if you walked in and a person had 2 kilos of marijuana on their table and 10 plants in their back room, that was good probable cause for arrest. After legalization, there were a lot more questions that law enforcement had and district attorneys had about what can we do with this now. And so you definitely see that really big drop off. And these even in the more serious crimes, we see this decline, right? Over the next 2 years, though, I think as we've seen more cartel activity and more organized crime that has moved into Colorado, we see increases in effectively all of these higher level filings for marijuana. In fact, when you look at manufacture, that's actually the highest number of filings that we've had in the last 9 years, was in 2016. And so, the issues that we are having in the black market are real. We really are working to get a hold on them, but as many of you have experienced, it's difficult. To put it in context, that 1359 is about 2.5% of all felony filings in Colorado, and that 724 before was about a little under 2%. And so it's not, completely exploding our court docket with marijuana felony filings. It's not. Is it increasing? Yes. Is it, definitely putting a strain on law enforcement when it comes to enforcement of this drug? Yes. But it is not completely exploding our court dockets. Okay, so the one thing, if you really want to start collecting information on impaired driving now, figure out how to do it, because this is the bane of my existence. People are really interested in this topic. It's in the Cole memo, it's in the Ogden memo, impaired driving, and we just have really, really iffy data on it. 2014, our state patrol started collecting information on what the trooper perceived as the impairing substance, right? This isn't toxicology. Our state patrol is very well trained. They have the most number of drug recognition experts. They're all trained in advanced roadside impairment detection. So if I have one agency to get information on perception of impairment, I'm glad it's the State Patrol, and I don't just say that because they work in my same department. And they also account for 20% of the DUI citations in Colorado. And so what we see here is, impaired driving citations overall, so the whole bar has gone down. It's gone down by about 1,000, which is, I think, about 20% in that time period. What we see, though, is that marijuana offenses, and that 781 number is marijuana alone or marijuana in combination with alcohol, marijuana in combination with other drugs. So from just 2015 to 2016, we have seen an increase of about 20% in that number, while alcohol, we've seen a decrease in about 5%. 2017 data, year to date, actually indicate a decrease in the percentage of cases that State Patrol is indicating as marijuana as the primary issue, which is positive, right? They're a really well-trained force. That training hasn't changed, and so we are seeing, and perhaps it is, in conjunction with what we've seen in the ED data, poison control data, that things are flatlining, but we'll see. One other way to get at this is to look at treatment admissions for DUI. So when you get your license back in Colorado after DUI, you have to go through treatment. These are the people who are reporting marijuana is my primary substance of abuse in their treatment. So when we look at, from 2008, from 2012 down to 2016, the number of DUIs in Colorado has actually decreased. Overall, they've decreased by, I write this stuff down because otherwise I completely get it wrong. They've gone down by about 10%, right? From 2012 to 2016. When you look at the number of people who are saying marijuana is my primary issue, that has gone up quite significantly by about 60%. And one of the issues that we really see here is when you look at treatment for DUI is very alcohol-centric. And And I'm sure it's that way in many of your states because historically our issues around impaired driving have been around alcohol. And I think what we're seeing is that is changing somewhat. And so as treatment providers, as people writing policy, it's important that we begin looking at, I think, the broader picture, not just alcohol, but alcohol and other drugs, not just marijuana, opiates, heroin, meth, cocaine. That drug driving is an issue that we are facing more and more. Fatalities on roadways is another way to get at impairment. This graph, the first chunk is actually the number of drivers that test positive for some cannabinoid, right? It could be delta-9, which is the active component in THC. It could be one of the active or inactive metabolites. This is all blood testing, so we're not catching the metabolites that stay in your system and that excrete in urine 30 days later, but it can stay in your blood for several days after last use, and if you're a heavy user, it can stay in your blood for up to 30 days. Anyway, so when we look at fatalities, which is that second chunk, in 2012, 55 of fatalities had someone tested positive for a cannabinoid, the driver did, and then it's gone up to 125 in 2016, which is our most recent year. The testing, so the questions I get about this, are more people being tested? The answer to that is no. The testing rate for drivers was 45% in 2012. It's still about 45% now. Dead drivers are much more likely to get tested than living drivers. Between 80 to 85% of drivers who are on a coroner slab get tested, whereas only about 15% of living drivers have their tests reported to our Department of Transportation. And so there are real limits to these data, right? And the 125 number in the last year we have data for is about a quarter of all of our fatalities. The driver did have some cannabinoid in their system. And in about 71 of that 125, the driver had delta-9. They tested positive for delta-9. Next question we get is, okay, they had THC. Did they have other substances in their system, right? 43% of the time, they only had THC. Relatively, so if you multiply those two numbers together, right, that 125 that had some THC in their system by the 43% that only had THC, that means about 11% of our fatalities, the driver had only had THC in their system. About a third of them also had alcohol. Almost 20% had cannabinoid and some other drug, and then 7% tested positive for the trifecta, where they have all three on board. And frankly, that other drug category, that can be up to 8, 10 other drugs that they test positive for. Okay, so what's happening with youth? So this is looking at our school data, our school discipline data. Until the 2015-2016 year, our schools did not break out any specific drugs. Marijuana was lumped in with all other drugs when it came to school discipline. And so what we saw was, so blue is the drug suspension rate, that jumps up after the 08-09, and then it effectively maintains while overall suspension rates declined, and then in 2014-2015 have effectively flatlined. We changed some policies to really discourage expulsions and suspensions for any misbehavior, frankly. And so, the fact that the total ones are going down, it wasn't surprising at all. When you look at expulsions, you actually see a somewhat different picture in that the expulsion rates, both overall and for drugs, have been going down over time. One thing though, this is on a different axis because the total number of suspensions is in the tens of thousands. The number of drug suspensions is, it's about 5% of all suspensions were for drugs. This is on the same axis because about 40% of expulsions, in Colorado were for drugs. They were drug related. So they finally did start breaking out marijuana in the 2015-16 school year, 2016-17 is actually the first year where we have complete data. And so what we see is when you, and this is looking at law enforcement referrals, which tracks the number of expulsions pretty closely. Marijuana violations are the second most common reason for a law enforcement referral in Colorado. So that's the green line. The orange line is drug violations. And so you can definitely see that other drugs, marijuana takes up about 70% of the drug violations that get reported to law enforcement, and about 70% of the expulsions are related to marijuana compared to other drugs. All right, and now I will hand it off.
Okay, so now we're going to talk about some fluffy stuff like the environment. We get a lot of questions about how green the industry really is, and the answer is it's not very green. It's actually one of the most energy-intensive industries that exist. So we have been tracking electricity usage of the industry here in Denver since about 2012. And since that time, obviously, electricity usage has grown to the point where it's now about 4% of total electricity usage in the city. There might be some things making this not the most accurate data, but this did come from Xcel Energy, and this is the best data we have at this time. So that means that 55% of the total electricity increase in Denver since 2012 is directly attributable to the marijuana industry, which is a pretty big impact. Slicing the data in a different way, about 30% of our operators use 50 megawatt hours or less of electricity each year. About half use between 50 megawatt hours and a gigawatt, and about 10% use a gigawatt or more of electricity each year. And the interesting thing about this is that the largest player in the market is using more electricity than the 138 smallest players combined. So it's there's a lot of stratification in the market where there are some major players and a lot of small mom and pops here in Denver. In terms of water, Denver Water did some studies and found that marijuana businesses use about the same amount of water as other comparable industries such as coffee shops or restaurants. They're not quite as water intensive as a garden or a nursery. So whereas an outdoor grow in California, for example, may use 6 gallons of water per plant per day, here in Denver we only allow for indoor growing. And that only uses about half a gallon to 1 gallon of water per day per plant. So it's actually pretty water efficient. In terms of where that water goes, Denver Wastewater was looking for loading, which is the introduction of unwanted elements such as soils, pesticides, or chemicals into our wastewater stream. And what they found is there just really is not much loading going on, so this is not a concern that we have here in Denver right now. In terms of solid waste, Alpine Waste and Recycling is a full-service waste disposal company here. As far as I know, they are the only company offering composting services to the industry in Denver. Their average customer recycles and composts about 12% of their waste, whereas their average marijuana customer is diverting about 18% of their waste to recycling and composting. So the industry truly is a little greener in that aspect. And then lastly, on environmental, in 2014, the city helped commission a health impact assessment for several of Denver's poorest and most industrialized neighborhoods. And it found that odor was the leading quality of life complaint, causing issues such as headaches, nausea, eye and throat irritation, and a general reluctance to go outside to do things like exercise, garden, or socialize. So altogether, 90% of the survey's respondents said that their lives would be improved if odors were reduced. And they identified marijuana businesses as the 4th leading cause of odor concerns, behind pet food and shingle manufacturers, and then meat packaging plants. So Denver responded by adopting an odor ordinance requiring all of these stinky industries to proactively obtain and utilize an odor control technology. And then the year following that odor control ordinance being adopted, we've had a decline by 44% in the number of odor complaints we are receiving. So that seems to have worked out well. Switching gears to the economic impacts. In Colorado, recreational sales began on January 1st of 2014. Since that time, recreational sales quickly outstripped medical sales and has continued to increase since that time into the present. Medical sales has stuck around, which has been very surprising for many of us who thought medical sales would drop off if you could buy recreational products. That has not been the case. It's hard to say exactly why, but a couple of factors are that some of the major jurisdictions here, such as Colorado Springs, only allow for medical sales, therefore people buy medical marijuana. And the other factor is that there is a large tax difference, so I think it's about 15% tax difference between medical and recreational products. So the market is incentivized to buy medical marijuana products, and as a result, those sales have remained fairly stable. Now, putting this into perspective, in 2016, $1.3 billion of marijuana products were sold in the state of Colorado, which is a lot. But the total gross domestic product of the state was $324 billion. So marijuana sales accounted for less than 0.5% of the total gross domestic product of the state. And to emphasize that point, I couldn't make my pie graph show it as anything other than 0%. So there's a lot of claims that marijuana has single-handedly turned around the Colorado economy. I don't quite see that the data supports that claim, but yes, we do have a lot of marijuana sales. Something that is true is that the revenue that the city of Denver is bringing in is basically, we're taking in more revenue than we're spending on direct marijuana regulation, education, and enforcement efforts. So the green here is our revenue. The blue is our direct expenditures, so that comes from that 3.5% retail sales tax that we have dedicated to those purposes. And the difference between these two lines, that money goes to our general fund to do things like rec center construction, sidewalk repairs, community health programs, and affordable housing. So the city is definitely recouping a little bit of money and investing back in the neighborhoods with the money we're generating from marijuana. Tourism is something people are always interested. There have been a number of studies commissioned to find out how legalization has impacted tourism. This example is a 2017 Longwoods International survey. And all the surveys I've seen basically say the same thing, that most people could care less that marijuana is legal. It doesn't make them more likely or less likely to come here. They just don't care. But for those who do care, it makes them slightly more likely to come here. So obviously the green outweighs the yellow, which is green is more likely to come, yellow is less likely to come and spend money. So legalization has had a slightly positive influence on tourism here in Denver and in Colorado. And then in terms of jobs, which is probably the hardest thing to report on, the Marijuana Policy Group, which is a local consulting firm here that specializes in analyzing the impacts of legalization, did a pretty broad study last year that took into account a lot of our key badge data from the Marijuana Enforcement Division. So that's the employment data. They took some general economic data and they took some industry survey data, merged it together, and came to a conclusion that about 10,000 jobs were directly created from the industry, with an additional 4,000 being indirectly created. So it's a significant number of jobs. When you look at the total employment in Colorado, it is just a drop in the bucket. And then finally, a couple of quick operational impacts on the city of Denver. What does it take from us to regulate this industry? Currently, Denver is home to 1,133 active marijuana business licenses, which operate out of 491 distinct locations, which means that Denver is home to 39% of the state's licenses, despite us only having 13% of the state's population. So at this moment, we are the epicenter of the marijuana industry in Colorado. Now that the number of licenses and locations has been stable since recreational sales began in 2014. I can't say that this is a result of market forces, but I can say that City Council has passed a number of moratoriums and then another moratorium and then a cap, all to maintain the industry where it is now. So we've seen this very slow and steady growth in the industry since recreational sales began in 2014. And as it follows, the number of applications we've received has remained fairly stable. So because you cannot just walk in and get a new license, pretty much everybody keeps their license. No licenses are being lost by attrition, 100% are being renewed. The largest workload we have are those renewals, which is the orange. Next, because you can't come in and get a new license, there's a thriving secondary market for buying and selling these licenses. So you'll see the green and yellow lines are sales of licenses, and those are happening a lot, so that people can get into the industry if they think they're gonna, make $1 million, but that doesn't happen, I don't think. But when you do buy a license or you decide to modify a license, 5 agencies have to come out and inspect you. So, and some of the agencies also do annual or biannual inspections. So altogether, Denver is doing thousands of inspections each year. We peaked in 2015 with just over 8,000 inspections being performed at marijuana facilities between the 5 agencies. And by 2017, we think we're going to start seeing it level off, but we are still doing thousands of inspections at marijuana facilities each year. In terms of the time commitment, an inspection will take on average between 50 minutes and 2.5 hours. So if you are trying to get a new license or modify an existing license or transfer a license, the city is going to spend, best case scenario, about 9 hours at your facility inspecting you. And that's assuming there aren't going to be any re-inspects, which some agencies have a re-inspection rate as high as 80%. So likely the city will be spending more than 10 hours easily at your facility, and that doesn't take into account the time to process the applications or hold public hearings. Now, Denver's been able to adapt to this workload by hiring an additional 58 full-time employees spread out across the various departments in order to basically handle the regulation, education, and enforcement surrounding the industry. So this has had a large operational impact on our city in terms of our resources and our time. But to end on a happy note, one thing we are seeing is that as the industry ages, it's maturing, it is becoming more compliant. So this is the average number of violations noted per food safety compliance inspection. And as you see, we are spending more time with them, and we are seeing higher rates of compliance, which is what we want. The industry is starting to get what we expect of them and work with us. So things are looking up, and they're moving in the right direction here in Denver. And I hope we're getting into a point of stability. So with that, we're going to open it up to questions. There you go. If you want to, does that work? You should do it.
If you have a question, just walk up to a microphone.
With the crime data that you presented, and the hospital data, is there any differential between synthetic cannabinoids and the natural cannabinoids that are included in those statistics?
In my court and my arrest data, synthetics aren't included.
They aren't included? Okay.
They're excluded from the poison center data as well.
Unfortunately, in the hospitalization data, the 4 codes that capture cannabis could also capture synthetic cannabinoids. There's no way to differentiate the two, but we think it's a very, very small amount.
Okay, thank you.
I've seen articles about opiate overdose admissions into hospitals going down. Is there any, I didn't pay attention to where the source of that data was from. Is that coming from any of your agencies? And is there or can there be any analysis of whether or not marijuana has anything to do with that?
I think that's a really important question, and I'm very excited to see more and more people devoting time to studying that question. One of the recent articles seemed to be very well designed. Looking at the correlation between opioid overdoses and the legalization of marijuana in Colorado. I think that that's something that deserves a lot of attention. The opioid crisis is very serious, and I think it's worth looking into at every level. Like I said before, the way that every data source, every analysis, every method has limitations, and one of the ways that we'll be able to tell if people are, successfully using marijuana as it's a harm reduction method. So if people are going to use something maybe using marijuana instead of opioids will help them keep going and reduce their pain. So that's the hypothesis. I think it would be great to see more studies on that, looking at, at the individual level. Do people who are using marijuana, are they successfully able to get off of opioids at all the different data sources level? So looking at the Poison Center data, looking at across different states, being able to factor in questions about anybody who has the capacity and interest in trying to reduce opioids right now is doing that. There's a lot of change. And so being able to account for all of the activity that's going on is an important thing to consider with looking at these two substances.
I'll just comment that the data that I presented did not show a decrease, and the reason for that most likely is because the way I counted the opioid hospitalizations and ED visits, I used the national standards for the ICD codes, the ICD-9 codes, but I didn't use their algorithm. I matched the algorithm to how we count marijuana, so that would just include any code in the listed codes, which is up to 30. But there's a national algorithm which counts it as being the primary diagnosis or the first poisoning code. So that's why you may see differences in the literature.
Anybody else? Okay, we can let out early.
One thing I should note that I should have mentioned, when you look at the Poison Center data versus the hospitalization data, opioids, in the Poison Center data, opioids are really high up, and they're below marijuana in the emergency department and hospitalization data. And I think that some of that may just be because Poison Center data is just a small percentage of people who call the Poison Center even go to the emergency department, so that data source may just be capturing much less clinically important exposures.
So the slide on Denver's revenue far exceeding the direct expense related to marijuana had built into that revenue, as I understood it, the 3.5% sales tax. Is Denver able to cover the inspection expenses out of licensing fees? Is there or does the whole cost of inspection exceed those licensing fees such that the licensing program, if you will, is really not self-sustainable? It has to live off of the tax revenue.
I'm actually going to ask Molly if she can field that question, because she is the budget expert. Do you mind? Thank you.
First, if you want to hear more about that, we'll be talking about it at the finance and budgeting session right after lunch. But the 3.5% tax, we kind of soft dedicate them for marijuana-related expenditures, and so that includes the inspections and from all the different inspecting agencies, as well as things like city attorneys, the Office of Marijuana Policy, and those about 58 FTEs that Natia had mentioned. And this includes all the different revenue sources. So the green line here is all the revenue sources: the 3.5% sales tax, the licensing fees, the standard sales tax. Everything, all marijuana-related revenue sources is represented here, and the smaller bar is all the marijuana-related expenditures, including inspections. Does that answer your question?
Is that a no?
It's a yes.
Permitting fees cover the total cost of enforcement?
With permitting fees alone would not cover them, but the 3.5%, but we don't necessarily directly correlate them together. So the 3.5% plus the licensing fees plus everything covers the inspection resources, then some.
I have a question kind of following up on the earlier question about spice and the synthetic cannabinoids. And I know that you said your data didn't cover that, but I wonder, do you know if there have been fewer admissions of youth with overdoses from the synthetic cannabinoids since legalization? Because I come from Las Vegas, and anecdotally, I work with youth in the court system. I feel like I'm seeing less kids being arrested for possession of spice or coming from the hospital for overdosing on spice since we very recently allowed recreational. I'm just wondering, do you have any knowledge in these jurisdictions that have passed this?
I think the Poison Center data might be the only data source we have that specifically calls out synthetic cannabinoids. I haven't looked at that before, but I think it would be worth looking at.
Okay, so unless, do we, okay, we have one.
I think it's just worth noting for the audience that when we're talking about the DUIs and the trooper data set with their assessments, that does not take into account local law enforcement assessments of DUIs and marijuana use. And that is a major, major data set when we're talking about cities, because troopers typically only work highways, interstates, and they do not often complete DUI stops within municipalities and even county jurisdictions. So a major, major data set is missing when determining whether marijuana is affecting DUI rates, you know, traffic accidents, that kind of thing, because those local municipalities, local law enforcement has not been, there's no data set covering that. I just think that's worth noting, because some people who aren't familiar with how local law enforcement is set out versus county law enforcement, state law enforcement, may not be aware of how that's enforced.
I know you're exactly right. There was a law passed last year that directs my office to basically collect toxicology information for all law enforcement across the state to get a sense of when law enforcement is actually making a stop and doing a submission of blood where they do suspect it's drugs, what percentage of those are actually going to be backed up and say, yes, this is drugs, marijuana or other drugs or a combination. We have data from Denver, the Denver PD and the Aurora Police Department, and both of them indicate probably about between 10 to 15% of their DUIs have a fairly direct relationship to marijuana.
Okay, now I think we can move to break.